Right, we're recording. So I'm joined by the amazing Dr. Kiriakidis from Embryolab. Have I pronounced your name correctly? Probably not.
It's fine, Sara, don't worry. My name is Dr. Kiriakidis. Everybody calls me Michael. And we are here together, me on the one part of Greece and you in the UK, ready to inform all the couples that are listening and watching us.
Yes, perfect. And today I want to pick your brains about a topic that is very close to my heart. PCOS, polycystic ovarian syndrome. I had this and I was diagnosed a very, very long time ago. But when I was diagnosed, nobody really explained what it was. And it was only when I tried to get pregnant at 32 that I realized it was going to be an issue. So today, it's almost like the conversation I wish I'd had when I first got diagnosed.
Mm-hmm.
So will you start by explaining what it is? What is PCOS?
Well, PCOS, referring to polycystic ovarian syndrome, basically, is one of the most common reproductive problems that women face, actually. It's included in a variety of disorders, namely androgen excess disorders, meaning the problems where androgens are overproduced in a woman's body. And polycystic ovaries, polycystic ovarian syndrome is the most common and famous, basically, out of these disorders.
And is it, so how common is it?
Well, we expect about 20% of women that are trying to conceive and not achieving their goals to suffer from polycystic ovarian syndrome. The problem with this particular syndrome is that there are many phenotypical variations, and some women may have some symptoms of the syndrome, but not the whole entire syndrome. So we miss some of the women that are actually polycystic, but don't have the necessary criteria for the syndrome itself.
Because I didn't have many of the symptoms. For me, the only reason I knew something was wrong was because my periods were so irregular. What sorts of signs should people look out for if they suspect that they might have polycystic ovaries? What are some of the common symptoms?
Well, the syndrome has a very wide spectrum of symptoms, and actually the women that have all the symptoms of the syndrome represent only about 10 to 20% of the population. So the most common of the symptoms obviously is menstrual abnormalities. Some women will face oligomenorrhea, as we say, so they have a very long cycle, about 40-45 days. Other women will have amenorrhea, so they will not see a period for several months. This is due to anovulation. Less common symptoms include androgen excess, so some hair growth. They will have other biochemical signs of androgen excess. And obviously, a small portion of the women will face infertility, actually, will face problems with fertility and conception, and that's the symptom that leads them to the doctors. The most common, though, is menstrual abnormalities.
And does it mean, if you have polycystic ovaries, are you ovulating, or might you be, or is it a no-no?
I haven't heard you correctly, Sara. Can you repeat the question?
Yes, yeah. I'm so sorry. I think our internet is a little bit unstable. But so does having PCOS mean that you don't ovulate?
Usually that is the problem, Sara. The polycystic ovarian syndrome is directly correlated to anovulation. And it's actually one of the ways that we are able to treat polycystic ovaries to help women ovulate. That's one of the ways that we use for the treatment. And that's the major problem with infertility, with difficulties conception. You understand that if a woman does not ovulate, the egg is not released, so there cannot be any natural conception. But before we reach to any medical treatment exactly, there are some other things that a woman needs to do before we reach to that point. There are other ways that we can help them. And we will discuss it further in a few minutes.
And can I, so if women with PCOS, we have periods, but like we said, sporadically. If we're not ovulating, why do we get periods?
Well, that's one of the, I think, the magical things about nature. Some women will see a period regardless of ovulation. And this has to do with a hormonal disbalance and hormonal variations that happen during the cycle, a woman's cycle. So basically, even though your body does not produce an egg, it continues to produce a certain amount of estrogens during the cycle. So if there is a drop of this of the estrogen production, it could be a very small variation. This could lead to the beginning of your period. So the woman does not ovulate, but she produces the estrogens necessary for a period. As soon as they drop, your period starts. It's basically what we call withdrawal bleeding. Mm. Your body reduces its estrogen levels and you have a period.
Mother Nature can be very cruel. To have a period for nothing is just, oh. So if somebody thinks that they might have polycystic ovaries, what do they do? What do you do? What are the tests?
Well, there has been a consensus since 2003 where the Rotterdam group has created the criteria for diagnosing polycystic ovarian syndrome. Okay, and women, in order to be diagnosed, need to have 2 out of 3 criteria, or the following criteria. The first one is basically menstrual abnormalities. Okay. The second one is a biochemical or clinical evidence of androgen excess, the ones that we referred earlier, like hair growth, hirsutism in certain cases. And the last one is imaging, is basically the appearance of the ovary as a polycystic entity. Okay, so women to be diagnosed need to have 2 out of 3. The first step in these cases would be a history. Okay, you need to see a fertility specialist or a specialized gynecologist that knows about polycystic ovaries to see whether there is any problems with your period, not only now, but in the past. The second thing that your doctor will prescribe is a certain series of blood tests to evaluate for your androgen levels. But a very important part is also a scan, an ultrasound scan that will reveal the appearance of the ovaries. Polycystic ovaries have a very specific image, a characteristic, I would say, for the syndrome. So if a woman has all these 3, then we are speaking about the full spectrum of the disorder. If a woman has a period but has 2 of the other criteria, then this woman has polycystic ovaries, but she ovulates. That's a very small portion.
Mm. And if it is shown that you do have polycystic ovaries, is IVF my only option?
Well, IVF is not a one-way road for women with PCOS. I would say the first line of treatment would be lifestyle changes. A big part of women with polycystic ovaries are obese or overweight. And that's not their fault. It's basically the connection between polycystic ovaries and insulin resistance, actually. So the glucose, the blood sugar levels are have a disorder. So the first part of the treatment would be changing the lifestyle, keeping a normal body weight or losing weight if they're overweight, A specific diet can be very helpful, and also we have very good results with some insulin sensitizing agents, medication basically that will help a woman's metabolism.
Ah.
This can greatly improve the periods along the way and can even help them ovulate sometimes.
Wow. Great. That's so great to hear that there are things that can be done to manage the symptoms. So if you were to do those changes, to have that medication, then there is a chance. Are you saying there is a chance then that you could go on to conceive naturally?
I actually consult my patients that they start with changing their lives and changing their daily habits early on. I usually wait for about 6 months to see whether the period will regain its normal form. Sometimes we may even monitor their cycle to see if they ovulate. And if they start ovulating, they can resume the tries for natural conception. Now, if this continues and we do not see any improvement, then I usually ask them to induce ovulation sometimes. Not entering into an IVF program, but try to induce ovulation. Combine this with sexual intercourse or targeted intercourse. And this way, we even improve our results this way. I usually try this for another 6 months after they regain their normal periods. And if by that time we have not achieved a pregnancy, then we can discuss whether entering an IVF program is necessary.
Is it hereditary?
Well, that's a very interesting question, Sara. Where it seems that there is a genetic association, and we know this because we see clusters of polycystic ovary syndrome in families. However, there is so far no evidence that there is a specific gene or a specific family of genes that directly passes on this trait to the next generation. But again, my sense is that there is a genetic basis with this problem.
Do you have to wait? Do you wait until you start your period? I'm just thinking about my little IVF babies who are now 10. So would I wait until they start their period to then get them checked out? Because obviously I don't ever want my children to go through what I've been through.
That's a bit puzzling though, because sometimes teenage women will have a polycystic-like appearance of their ovaries. That doesn't necessarily mean that they suffer from the syndrome. Also, in the first few years of their reproductive lives, women have an immature hormonal axis. So sometimes they have menstrual abnormalities, but this is later on regulated. The first few years and up to the early 20s, I would avoid doing any screening, but because this may frighten you and scare you, okay? But if by the age of 25, women do not have a regular monthly period, then they should seek assistance and see whether they can regulate their period or if they have any problem with polycystic ovaries.
Okay, that's very useful. Honestly, I've put down on my to-do list for my children, PCOS testing, egg freezing. I mean, I have literally got a list of things that I would have done had I known everything that I know now. It's crazy. So just to summarize what we've discussed today then, so just because you have been diagnosed with PCOS does not mean that you will automatically have to have IVF. It's all about changing your lifestyles. There's medication. There are things that you as a doctor can do. So don't panic.
Exactly. Panic is never a good help along the way. Polycystic ovaries can be treated with lifestyle changes, can be treated medically, and in some cases, the need for IVF may appear in the future.
Yes.
Again, the syndrome itself has in general a good prognosis. It has to do, however, with other confounding factors such as age of the woman that she's diagnosed, how severe the problem is, okay, and if there is any added problem like a male factor or a tubal factor that needs to be accounted for. So polycystic ovaries, we know at this point that in general, women with polycystic ovaries have a very good prognosis, either way, IVF or not. Sometimes they will need IVF. In these cases, they need to be very, very careful because the doctor and the clinic that will treat them need to be experienced, because polycystic ovaries come with certain side effects and certain complications along the way, okay? So one of the most common complications that we see in PCOS women is ovarian hyperstimulation syndrome. So you need an experienced clinic and a doctor that will see in advance the risk, and because there are ways to avoid it, and very practical ways to avoid it. In our clinic, we haven't seen OHSS in the past 6-7 years.
Wow, that's amazing, because I've shared with you before, I had severe OHSS and, you know, was hospitalized for 2 weeks and had to be drained, and it was a terrifying experience. One thing I would say is to take this knowledge and be aware of your own body as well, because I ignored pain. I didn't listen to the doctor who said, be careful, you know, be careful, this might happen. I just didn't want to know. I was too concerned about having my children. But again, in hindsight, I would have put my hand up a lot sooner and said, I'm in pain. But
that's exactly what I do as well. I always advise my patients to be patient. Sometimes you need to wait for a few days. You may need to wait for a few weeks for the situation to resolve before you proceed to the next step. But this is always keeping in mind the safety of the patient.
Well, I think, I mean, like I said, I wish I'd had this conversation years ago. I really do, because I think there's a lot that I could have been doing myself in terms of diet and medication and just having conversations. So I hugely appreciate your time today, and I know this is going to help so many people. So thank you so very much.
Thank you, Sara, for the opportunity that you gave me to discuss with you this very important matter. Many women will have questions, so if they have any new questions, I'm always at your disposal to answer these.
Thank you so much.